All right. My name is Napoli Bry, and I'm the project manager here serving within Fort Bend County Health and Human Services, and I'll be your host for today. We're going to go ahead and go over some housekeeping rules before we dive into this webinar. Again, make sure you click the live transcript button to enable your closed captioning feature. And also, if you would like to ask a question, feel free to utilize our Q&A feature as well. We have Jasmine Barnes, my colleague, who will be helping man the chat today. And any questions that you may have, we hope to get those addressed for you. Also, a little reminder is that we do have a survey at the end of our presentation. Let us know how well we're doing. Uh, just let us know if this was a helpful webinar and anything that we can work on for future stay. So a little bit about the PHWP, or our Public Health Workforce Pipeline. It was developed at a TACHO conference in 2022, and it basically came to conception as in response to the within COVID-19 and the shrinking public health shortage. And out of that conference is the development of this workforce pipeline. What's really unique about it and really great is that it's very much sustainable. It's very inclusive to public health careers and really adds that great information of like skills development, professional growth, strategic collaboration, and also education to all of those, whether you're clinical or non-clinical, whether you're interested in a career in public health. Um, Today, our workforce group, is the communications workforce group. We're one of a few groups that work in collaboration with the whole pipeline. So one great thing is that our job is to make sure that we share public information with everyone, each of you that has joined us today. We just offer that support, and we love to involve our stakeholders in this process. So a little bit about public health. So we like to say public health is everywhere. Public health, you would see it whether if you are looking at it at the educational level, whether it's your public health teacher, your nurse, or you might see it in a local health department whether we're providing you with further education about maybe some kind of health concerns, or educating you in cardiovascular disease, obesity. You might also see it at the state level. You might see public health is everywhere we go, basically. What's great about it as we dive into the emergency preparedness series is we're preparing for this World Cup for FIFA, and emergency preparedness is going to be key as far as our the public health workforce, and helping us work through this international event that's coming to town. So again, this public health passport into public health series is great because it allows us to engage you all, whether you're a student uh, going to college, whether you are a health professional that's looking for a career change and that's in public health. This will allow you the avenue to really understand what it is that public health, what we do as public health professionals, and the various options as far as careers that you have. So today I want to introduce you to our four panelists. We have Kenton Barnett. We have also Charles Brockett. We have Jesselyn DeMano and Dr. Beth Ann Moscove. As we move further in this webinar, they will introduce themselves and share their experiences and insights throughout their various roles in public health. So we'll go on and move forward, and I'll give the floor to you, Kenton.
All right. Good morning, everyone. I'm Kenton Barnett, Senior Training Exercise Specialist for the Preparedness and Response Program at Texas Department of State Health Services. So a little bit about my background into this journey. So as you can see from the slide, dual degree in public health and business administration. However, public health was more my focus than the business side. So what really initially sparked my interest in public health was way back in undergrad during college. I had during freshman year, there was one of our mentors, and they kind of mentioned public health, and that was my first time hearing about the field. And ever since then, it was always kind of in the back of my mind before it became to the forefront of my mind. So towards the end of my master's in 2019, I did an internship with the agency I work for, Texas Department of State Health Services, and it happened to be in preparedness. Based on your program, you may or may not get experience with preparedness. I know for my MPH, I had no clue that was a field until I did this internship. And it just kind of, things fell into place in a certain way where I was able to, get into preparedness through that internship eventually. During a COVID setting, I was actually working as a teacher before this. So I happened to do it one of my summers off. And then in 2022, as the pandemic was trying to winding down, I was able to transition into public health emergency preparedness at Region 65 South. And we can go ahead and go to the next slide, please. So just a little bit about like the preparedness program. One question sometimes people ask is like, well, what's a normal schedule? Well, in preparedness, from my perspective, there really isn't such the thing as a normal schedule, simply because you never know what's going to happen. So I feel like you spend about 90 to 95% of your time preparing, but that response time, that 5 to 10%, you don't know what's going to happen. It could be something like severe weather. So we have responded to hurricanes and winter storms. And depending on the severity of the situation, sometimes you may be activated for a couple of days or a week. Sometimes you may be activated for a month. When it comes to biological threats such as mpox or COVID, obviously, the response could take way longer than anticipated. So there really isn't a typical schedule. So for my role as training exercise specialist, it's the main role is in the title. So I help develop trainings, conduct trainings, or bring trainings into the region. And right now our region covers 16 counties. So pretty much from as far west as Matagorda County, as far east as the border with Orange County, as far north as Walker County, and then everything in between Houston, Harris, and Fort Bend. That's our region. And so either we're working with a local health department, just trying to help them with, assistance as needed, or we're in one of our counties that do not have a health department and helping them prepare and coordinating with their emerging managers just in case they have certain issues that they're trying to address. As it comes to the World Cup, it's one of those things that we've been planning for a long time. One of our first major exercises that we did for this was last year, and we did a biological agent threat. What would that look like if somebody came in and, dispersed the biological agent either at FanFest or at the game, and how will we prepare and respond to that? So, we spent a lot of time over the last couple of years just coordinating with partners from, various disciplines, not just public health, but also law enforcement, fire, you know, civil support teams, which deal with radiation. There's a lot of different disciplines that we interact with, not just public health, just to make sure that everybody's on the same page and that everybody is trying to respond in a coordinated manner. So as we know, World Cup officially kicks off tomorrow. And so, my schedule personally has just been preparedness meetings, drills, exercises, and pretty much almost all World Cup in 2026 and trying to fit in regular work in between. So that's a little bit about me and my background, and then we can go ahead and go to the next slide.
Thank you, Kenton. All right. And You could feel free to answer these questions in the order that they appear.
Yeah. Okay. So for these questions, like I said, that initial passion, once that seed was planted in undergrad, so like my major was actually biology, but it was a while before I actually, switched to public health. I could just never get it out the back of my head. So like somewhere like during my teaching career, I decided like, hey, I think I want to go ahead and pursue MPH. And for context, I was a teacher for a decade, so I was in the field for a while before switching to public health. And so because I couldn't get it out the back of my head, you know, that's what led me to pursue an MPH. And I feel like some of the biggest challenges in public health is one, I just say awareness. Because, when I had conversations with people, in the general public, a lot of people aren't familiar with public health, or if they are, they kind of have a bad taste from COVID. So there's a lot of negative perceptions of public health. And I feel like one of the biggest challenges is just improving our PR, our public relations, just letting people know that, hey, we're here to help, not to harm. We're not to make your day worse. We're not here to try to tell you what to do. We're just trying to keep the community healthy. We're just trying to keep the community prepared. And so in my experience, like, what has changed the most is sometimes I kind of, wonder how can we do more? How can we help out in the community more? Because I feel like one of the biggest challenges is like, workforce. There's always a need for more people to do more things. So I feel like it's always a challenge to try to get everything done that you want to accomplish at any given time period, just because, there's so much work to be done in public health, but I feel like there's not enough people to do all those things. And then funding can sometimes be an issue as well, too. How do you make it stretch? And those are some of the biggest challenges that I've seen since I started working in public health.
Thank you, Ken, for sharing that information. Yes, you touched on a lot of things, especially that, how you mentioned COVID and how that caused the shrinkage in the workforce, the public health workforce, and then also some of those misconceptions that about the field itself. But the you did touch on the importance of it, of this field as well, and so many different avenues, so many different roles and people that come together. And again, this further just solidifies the importance of these theories that we have, to just bring people back into this workforce. It's so important. We're going to move on to, thank you for your time, Kenton. We're going to move on to our next panelist, which is Charles Brockett.
Good morning, everyone. Charles Brockett, Fort Bend County Public Health Emergency Preparedness and Response Division. We usually say FEPR. It's not easier to say that other than that whole spaghetti I just mentioned. But my background started in EMS. Actually, I started as a EMT and paramedic in Los Angeles County. Worked there for a little while. Did some movie sets and worked on offshore oil rigs. Did some training with a supervisor and also FTO and then a manager. You do that when you're young. Your body will tell you eventually excuse me, when it's time to get off the ambulance and start hearing fire running down the road with lights and sirens. Your body will let you know you need to start doing something else. So about 2015, I started thinking about that. I loved EMS. I was in it for about total of 25, 26 years. Had a great experience with it. Loved helping out each individual I came in contact with. But like I said, your body will tell you when it's time to maybe either do something else that's not so taxing, or usually go into maybe what we old time paramedics that go into teaching is what they end up doing. I don't really teach that well. I'm a good student, but not a great teacher kind of thing. So I looked into my options, and I found out that there was a brand new emerging emergency management division that kind of piqued my eye because it had the word emergency in it. So I focused on that, found out what it was, and it helped me then translate into emergency management and with a public health aspect to it. So I got my second degree in actually emergency management certified, and then also in public health awareness and public health assistance and associations. So I got that and decided to go to a desk job and save my back and That way I can get up and walk around in the morning and not have to use a walker or have my son carry me around the rest of the day. So that was my introduction into emergency management via EMS. It was a way for me to start doing more work, helping more people than just one call at a time, but now I can help a lot of people at one time or even over a period of a long stretch of time. So that was my draw to it and my liking for it. Next slide. So kind of what we do in emergency preparedness here at Fort Bend County Public Health. We do a lot. We interact with every division. We are the liaison between public health and our emergency management, first responders, our EMS, our fire, our sheriff's office, our constables, even with our EOC, which reaches out to our Texas State Guard and our partners like Kenton and his cohorts in crime up there at DSHS. They help us liaise with them, and we do the same back into Fort Bend County. One of the major things we're working on right now, compared with FIFA, is we're working on the HCID plan, or that highly contagious infectious disease. In emergency preparedness and response division, we do a lot of emergency plans for the county and how we interact with our agencies, but also for the Fort Bend County Public Health in general. We work with our clinical health division. We work with our environmental health division. We work with our outreach division, not just supporting with assets, but with our plans and then actions of how we can then support if there's a real event, and then of course educate the public on what they can do. The better we educate the public, the less work we're going to have for ourselves when we really have a real event. And that's kind of the overall goal for emergency preparedness and response. You may think of it this way, just trying to do as little work as possible when the event happens. That's a goal we'll never get there. But that being said, it is something we strive for every day with planning, training, education. We work with Kenton and his divisions a lot with training and education. We do that here in Fort Bend and in the region also with our partners, so that we know faces and names when we have an event, so we can interact with them much more readily and seamlessly. We do, like I said, operations and incident command planning. So we do training and credentialing here with my staff, and then also internally in HHS. We have a platform directed by our LHA. That's local health authority. We use a lot of abbreviations in emergency management. If you guys haven't figured out, there's a lot of shortages we do because it's just too much to say at once. So our local authority, Dr. Gail Lowe, has actually have a mandate that we're going to be actually having level of education for our essential employees that we have here in Fort Bend County HHS. So we're part of that program, working with our EOC and also partnering with Kenton at the state for education. A lot of what I do is based on, I have grants that I get every year from the federal government, state to us. So I buy assets and supplies. I have a large warehouse behind me, which we have many, many shelves. We stock up supplies based on what we call as an HV, or hazardous vulnerable assessment. We know what our events that have occurred at least one time or more. We have assets needs for those events. We buy and we purchase and we plan and we exercise based on that, so that we're putting effort behind knowledge so that we can train better for things that actually we anticipate will and can happen again. They don't, great. We're better off, but the chances are they will. So we buy assets, we have training, we have exercises that pertain to those vulnerable entities within our county and occurrences within our county and within the region, so that we can then supply it, train for it, and then respond to it. And of course, more important than anything else, recover. We have to recover from those events. We have to get back to what we call blue skies. Gray skies when you have the event occurring, you're up to your eyeballs in alligators. And then the blue skies, you try and get back to it as soon as you can, because that's normal life, normal operations. And that's where you're always striving to get back to. We have heat and cold environmental responses. We have pre-packed tubs for pre-selected locations here in Fort Bend County. We have cooling centers, warming centers. We have shelter sites. We have already scouted these sites. We have them on our actual list that we have for deploying these pre-packed tubs that are already staged there. Our Emergency Operations Center, or the EOC, is aware. They actually partner with us to open these up with facilities. They have the keys. They can turn on the AC or the heat, whatever's needed. We, HHS, we then go in and support the people that get there and the animals. Don't forget that, the pets. That's something we've actually incorporated to our plans, is, of course, our other furry family members that will accompany a lot of people that come to the shelters and or centers. So we have mitigated that. We have kennels, and we have water bowls and food bowls. We have food we can get from our animal services, which is part of public health. And then lastly, of course, on the slide there, training exercise. I kind of hit that already, but we do a lot of training. We're doing more than we have in the past, basically because it's that muscle memory we want to develop. We have a plan. We need to exercise it, test it, see how well it works. Lots of times we're fine. We're going to have to take those plans. In my division, we'll take them and exercise it, and we have to pretty much tweak them or conform them better because we find out some of the operations or even some of the actual functions are not something we're capable of, or it didn't work very well. And then we change it or modify it or even eliminate it. We just recently did a pod and shelter exercise simultaneously here in Fort Bend County with our Texas State Guard and our EOC, our Emergency Operations Center. It was very, very good. We partnered with them. They bring in a lot of support. They being Texas State Guard. They have backs and arms that can move our assets. They can help us put people through our lines. They can help us move assets when we deploy and then when we demobilize both. They help us get an organized structure to put people through so that it moves smoothly so we can actually do it with our objective for that either goal of the shelter or the pod gets completed. And the EOC, our Emergency Operations Center, they are the coordinators. They coordinate all this for us. So they get us all together and then they start helping us move what we need from point A to point B and then back, and then help us then demob it when we're done. So that's kind of in a nutshell, really quick what we do. There's a lot more, but you can get a general idea of what it is. Next slide, please. Kind of what I was earlier, where my passion from public health come from. It started in EMS. I was a paramedic on the EMT for many years, helping one person at a time. Now I wanted to do more than that, more people at longer periods of time. So that's kind of why I moved into emergency management. And like I said, I'm a better student than my teacher. So I couldn't teach, but I did find I have a knack for emergency planning and getting assets to where they need to be and train. So it kind of was a logical move for me. And I can stand up straight and walk, so my back doesn't hurt. It's great. My knees are great. So how did you know public health was for you? I started actually in California, like I said. I worked in Kern County, Bakersfield. I went into public health there as an EMS coordinator. I had a lot of responsibility for our coalition, our emergency plans, our training, our exercises. It was really, like I said, it was doing what I was doing in an ambulance one person at a time, but doing it on a much bigger scale. And it was for me, it was very satisfying. I enjoyed the work I did. I enjoyed being AC and being in the heat when it was cold or hot. That was very nice. Being out in ambulance, it's a little rough on the thermostat of your body. So it was very appealing in all many ways. So I did know once I started at public health, I didn't want to end, and I transitioned from California to here to Texas and stayed in public health. Challenges, and Kenton didn't mention this before. A lot of challenges I'm finding just from other states and here is funding. That is a constant fluctuating master. It is something you have to adapt to, and you have to sometimes adapt to it on the fly because you don't get a lot of notice sometimes. But that being said, in preparedness, you use that HVA, what you know you're vulnerable for. Get those assets, prioritize them, get them on your shelf so that you have ability to respond and to fill those gaps. There's always help. There's always going to be neighbors. You reach out to them, develop those relationships. That's what we do here. Everything from pushing out star requests to actually doing a regional partnership. When we do exercises, we do any type of meetings, we partner with them. We talk about what we can and can't do, what we bought and haven't bought, what our exercise is coming up and what not coming up. So those are things, those relationships are really, really vital in getting a good, strong preparedness. So if you aren't developing those, you're going to have a lot of challenges. I'll just say that. And experience has changed your view of most. Well, in my personal opinion, I'm looking for the next generation already. I'm trying to look for that new and up and coming emergency preparedness. Emergency preparedness division within public health is kind of new, kind of like emergency management itself. It's a newer field. So there's not a lot of knowledge of it. In fact, even in your own building, sometimes there's not. So getting that knowledge out of what emergency preparedness is, what they do, how they work. You see us during disaster, sure, but then, during blue skies, when everything calms down, you don't see us very much, but that's the time we're planning, we're preparing, we're adjusting those plans, we're planning for the next exercise, preparing it, communicating, networking, working with our different partners here in the region. So that experience has really changed how I view public health in general. It's what I'm saying here is a lot of what's being practiced here in the region. So it's very hopeful and very rewarding in doing that. That's all I got.
Thank you so much, Charles. Yes, you hit the nail on the head, and Kenton did too, especially about funding, how so much in public health that we are greatly impacted. It is a field that is greatly impacted by funding, and how you have to get very creative sometimes, innovative, as far as making sure we are meeting the needs of our communities, of the population. So thank you so much for sharing that. We're going to move on to our next panelist, which is Jesselyn DeMano.
Hey everyone, my name is Jesselyn DeMano. I am the Vulnerable Population Specialist for Specialized Health and Social Services here at the Department of State Health Services. And what's unique about my position is that I get to partner with our emergency preparedness team. My journey into public health really started when I was in college. I received my bachelor's in health and human services. And then I went into a residential facility where I was assisting people who had chronic co-occurring disorders such as mental health and substance use. I did that for a few years, and then I moved to Houston in 2012, where I began working with the unhoused population. And this is really where emergency management and public health kicked in. I got to meet people where they were at on the streets and where they were basically at. So I was in the woods, I was working the street corners and going into do InReach and other organizations that touched upon HIV and other illnesses, as well as, you know, mental health and substance use. During COVID was when it really hit me that these folks need help. And so we would do testing for COVID, get them into hotels to be isolated. And then we would go out and continue to check on people, boots on the ground. I then went to the Coalition for the Homeless, and I helped the communities to identify where their most vulnerable people are, and continued with providing them like essential information and resources, as well as organized a structured way to assist those during an emergency disaster. We were in the warming and cooling centers, helping those who would go with us to be transported. We would help the folks get back to where they were at, as well as get into housing and other entities. For DSHS, you know, right now I get to currently create some specialized health brochures that are geared towards all populations. So seniors to children, mental health, substance use, pregnant women. I'm working on a few projects towards like hazardous wildlife in the Houston area, substance use activity book, and the suicide prevention book that's geared towards volunteers going into the shelters to recognize the signs and symptoms of who is experiencing suicide. So I'm very new to emergency preparedness. I've been at DSHS for 2 years, and being a part of all the exercises and drills and tabletops has really been eye-opening for me. I've taken a lot of FEMA courses, and on the back end, I help the HS staff with making sure that they are okay through alert media. And then I'm also available for any other physicians that need assistance. So that's really where my journey started and what I'm doing now. But really people and helping them is my passion. So you can go to the next slide. And I think I actually covered this as well.
That's okay. Okay, we can go to the questions slide. That's okay with you.
Yes. So, like I said, my passion for public health really comes from working with people. I am driven to making sure that folks are okay and be able to help them in any way possible. Um, I really didn't know that public health was for me when I was early in my career. I was a little nervous. I thought I would go and get my MBA and go into business or become a residential counselor, or not a residential counselor, but an admissions counselor to get students into college. Um, some of the biggest challenges that I face are um, really getting people connected to the information and resources that are available to them. Um, we focus on very rural communities, and it's very sparse with the resources they have out there. Whether it's connecting to healthcare or, you know, even getting into a shelter, there's a lot that don't do shelter, that everybody stays in place. And public health has really changed my view with the work that I do, because anybody can become vulnerable at any given time. And that's really what drives me. So I went from working with one niche of people to now the whole community, and that has really helped me. And that's next slide.
Thank you, Jesselyn. Um, thank you for touching especially on those two issues of mental health and homelessness. Those are priorities that I think sometimes may fall by the wayside, but they're very, very important to be addressed. And also how you mentioned you have the heart for public health. That's super important. And that passion, public health, you really have to have the heart and passion for the work that you do. So thank you so much for sharing your experience with us. And we are going to move on to our last panelist, who is Dr. Beth Ann Moskov.
Great, thank you so much, and thank you to the other panelists. Hard acts to follow for sure. So I'm Beth Ann Moscow. I've been in public health for some time now. I'm all mostly in international and global health. I started my journey like everyone else in college, and I was confused when I was in undergrad. I was going to either be an investigative journalist in war zones, a famous actress on Broadway, or I was going to be a trauma surgeon working in New York City's biggest hospital. So of course, trying to consider all of those things, I end up in public health. So I kind of explored all of my different options, and I was very confused after college. So I thought the best thing to do to figure it all out was to join the Peace Corps, which was a phenomenal experience and really helped me to understand sort of the public health aspects of life. I did both agriculture and health work, using agriculture as a means to improve health, also clean water as a means to improve health. And that kind of really introduced me to the whole concept of public health and what it meant. After Peace Corps, I thought to myself, well, do I want to wait until people are sick or in some kind of a situation to help them? Or do I want to try to prevent situations from happening and prevent, people from getting sick? And so public health just felt like a natural sort of, marriage for me to look at in terms of my job. So, but I still had the adrenaline sort of desire, the adrenaline junkie desire to work in emergencies. So I started working in emergencies, first in the Rwanda and then Zaire genocide. And it was sort of, I was working for the Hawaii State Department of Health, but I needed to get back overseas. I was missing it too much. And so I was hired in by UNICEF and went and ran, first we were doing programs to sort of get, children who were unaccompanied back with their families because they'd been separated by war. We were trying to get the healthcare system set up and running, but we were also, I spent a lot of time managing or negotiating with rebel leaders, the movements of populations, internally displaced persons and whatnot. So there was a lot of different things that I was doing at once, which is the nature of emergencies. I think Charles, certainly touched upon this. It's not just, and I think Kenton as well. You don't just go and talk to your EMS or talk to your hospital. To manage any kind of an emergency, you have multiple sectors and multiple folks involved. So thinking about a career in emergency, you have to be able to juggle all of those different pieces. And certainly working in a war zone and in a genocide, you get that experience. When I finished my time with UNICEF, I was absolutely in deep, and I said, well, I really need to think about continuing my career in public health, and that's what brought me to USAID, which, as we all know, has now been defunded under the current administration. But I spent about 20 years with USAID. I served tours in India, um, Russia, Ghana, Mali, Washington, and then Ethiopia. And so at USAID, I would go into a country and we'd look at the healthcare system writ large and see what kinds of improvements needed to be made in that healthcare system to improve overall population health. So maternal child health, infectious diseases, looking at the system itself, trying to reduce under five mortality, reduce maternal mortality, reduce HIV, all these different kinds of things. Inevitably, I think every country that I worked in, some kind of emergency came up, and so I got sucked into all these different emergencies. The joke being that when I turn up, an emergency is going to happen in the country, so be careful. So I've worked on multiple infectious disease outbreaks. I was on the forefront of the avian influenza outbreaks when it was happening in various parts of Africa. Again, when there's been conflict in India, I worked on a couple of different earthquakes in terms of managing that type of part of it. The biggest contribution I made in terms of emergency management was during the Ebola outbreak, the big Ebola outbreak in 2014 to 2016. It was interesting at the time of that outbreak. A lot of folks were sort of thinking, oh, we've got it resolved and we know what we're doing. But in the reality, it was a huge, disaster brewing. And so I came on board and spent half my time in the field trying to do things like get our Ebola treatment units up and running, make sure that populations were safe, negotiating planes able to land with special landing rights because they were carrying supplies, etc. And this was an Ebola. These were Ebola affected countries in West Africa. And then the other half of my time I spent in Washington negotiating with Congress and the Senate and the White House for more resources and how to move our money. So again, lots of layers, not just boots on the ground, which is my favorite thing to do, but you've got to have the policy in place, you've got to have the resources in place, you've got to have the right players to work with you to get things sort of moving. So during my time, I absolutely loved my time in the Foreign Service, passionate about working in Africa, my favorite place to be. But I also reached a point where I thought, you know what, I think the best thing that I can do is help to work and inspire the next sort of cadre of public health leaders, while at the same time looking at how to continue to improve systems. And so that sort of, made me decide that I wanted to come into academia, which is then what brought me to University of Texas, the Health Science Center, where I did my PhD in health economics, and then also continued to consult I did a lot of consulting under Biden on how to improve our COVID response. We made a lot of mistakes during the COVID for our COVID response, so things that we could do to improve our COVID response. And so now I balance and I think we can probably go to the next slide, just in terms
Sure.
of the things that I'm doing. Yeah. So just a couple of things. I think I've talked about some of these things already. Now the way I'm spending my time is in a couple different places. First, my primary position is at UTMB, University of Texas Medical Center at Galveston, where I do a combination of things. I teach at both the School of Public Health as well as the medical school. My focus is on infectious disease, emergency management and preparedness, global health governance and diplomacy, health systems, strategic planning, these kinds kinds of things. We also have several partnerships, particularly in Egypt, with several medical schools in Egypt. So I go to Egypt several times a year to teach at the medical schools there and help do research and build curriculum there. Um, I'm working now on a new project in Libya to help redesign their national healthcare system. But I'm also doing a lot of work with looking at our pandemic response. Again, I've designed a whole series of courses for public health students on emergency pandemic preparedness, emergency preparedness, planning and response. A quick little data point, during the COVID outbreak, about 80% of public health workers had some role to play in the COVID response. However, only 4% of them had some kind of formal training in emergency management and preparedness and response. Okay. My perspective is that, if you're going into public health, at some point you really should take some kind of a course or some kind of a training in emergency management and preparedness, because when it's all hands on deck, you can get thrown into doing things that you never even thought existed, but they have to get done. And so it's a critical part of it. So a lot of the curriculum and course design that I do is to help better prepare our students for emergencies, moving forward. So that's what I do at UTMB. I also work with UT Health as a faculty associate on the Prevention, Preparedness, and Response Consortium, which is a P2R consortium. And this is this is sort of a collection of different types of training, online, in person, professional development training, which looks at not just pandemics, but also general kinds of emergencies, how we can do better training, and again build that capacity, our workforce capacity. We did a lot of workforce capacity in throughout my time at UT Health. My dissertation research has been looking at Texas and its capacity to respond to pandemics. I developed a kind of a new innovative three-prong approach for how counties can improve their pandemic preparedness and response planning. It can be used for any emergency, actually, and so I'm sort of rolling that out and working now with NIH and CDC to look at how we can roll this out nationally, because it really improves our ability to plan for prepare for emergencies. So I think I'll stop there. I can talk forever, as people know. We can go to the next slide.
Thank you, Dr. Moskov. And feel free to touch on the questions that you may not have addressed.
Yeah, sure. So my passion for public health, it comes from so many different places. One of the things I love about public health is, this year you're working on an emergency. Next year you're working on systems building for, improving children's health. And then, 6 months into that, they need you to do some work on maternal health. And then you're thinking about TB. And then what about HIV/AIDS? It really is sort of a very comprehensive approach to looking at the population writ large and how you can improve the overall health. Well, improving health is not just one single thing. It's multiple things. And so I love, in public health, that we can do so many different things and bring so many different entities together to make an impact and a difference. And for me, I think that's just, that really creates my passion for public health. How did I know public health was for me? I will tell a very quick story about what sort of transitioned me. This is when I was a Peace Corps volunteer, and I worked in several different villages. And one of the villages I worked in, the first day I went to that village, they were growing onions and tobacco. That was it. A lot of sick children, a lot of malnutrition, a lot of different things. It was a real disaster in that village. So I worked together with the women's group, and we started an agriculture cooperative. We had all the women, divided up into teams to water these gardens. We negotiated with the village chief to get land space, and we were growing, tomatoes and lettuce, and we were growing all kinds of greens. We were growing zucchinis. I mean, you name it, we were growing it. And so we spent 2 years going from tobacco and onions to this very vibrant garden, and half the food from the garden that was distributed amongst the women, and the other half was sold. And the gardens that the money that was made from the food that was sold was put into like a general sort of little loan. So when kids were sick, they could borrow money and buy medicine and all that kind of stuff. Anyways, last day when I went to go say goodbye to this village, my favorite village, they threw a big going away party for me that I was leaving. And one of the gifts that they gave me, the final gift that they gave me, was a plan for next year's garden. It showed me what they were going to grow, how they were going to distribute it, how they were going to save money, how they were going to improve the health of children. And I stepped back and I thought, this is public health. This is what it's all about. And right then and there, I said, I don't need to be an actress. as much as I would love to be. I don't need to be a trauma surgeon. Public health is for me. So I think that was sort of my story there. Challenges. I think we've talked about so many challenges. Funding, people understanding what public health is. All of the above. Completely and totally agree. Um, every time I have a public health experience, it changes my view, and then I think, oh my gosh. I'm going to do things totally different. And then the new experience comes along. And so I think that's, again, building upon all of the different components and different spaces that we work in public health. Each one of those experiences collectively changes our view. Sometimes, usually for the better. Sometimes it makes us a little bit cynical and concerned. I think probably the most profound experience that I've had has been two things. One is working in a war zone or on the genocide, and then two, working on Ebola, and seeing the complete and total system failures that we had, in terms of managing this large scale infectious disease outbreak, and then bringing into COVID, which was a total failure again, and seeing that despite all the work that we've done, there's so much more that we need to do, and there's so many gaps that we need to address and deal with, and so it's just a never-ending, process. Even though we think we have accomplished a lot, there's so much more to accomplish. So I will leave it at that and turn it back over to you.
Thank you, Dr. Moskow. And like your you, thank you for sharing your background with us. It really speaks to how there's so many different avenues that one can serve, and they may not even know that they are doing the work of public health. Very inspiring. And also, I think one other thing before we move on to our Q&A segment, many of us that work in public health, this is more for those who are new or maybe thinking about joining public health, the public health field. Many a times we hear each other say, we did not necessarily set out for looking for public health, it found us. So I'll just leave you all with that little thought, and we'll move on to our Q&A segment. We do have about 2 questions that are geared specifically towards 2 of our panelists, and then the other questions is, they're open to all of our panelists to join in and comment on. For the sake of time, we're going to spend about 1 minute or so on each of the questions. So for the first question, this is for Charles Brockett. How can local health departments prepare if we are not a World Cup hosting location? Do you have any advice for clinics?
Yes, and there's several of those. This is a very large event, as everyone knows. It's been advertised as that. It's been publicized as that. It's been on the news and everywhere else. There's going to be a large contingency showing up for the games. Also, is there going to be a very affected area around the games? I mean, even in Houston right now, they're shutting down a lot of roads. People that actually live over there, they can't even get home. They have to have special badges. One of my staff lives over there. She has a little key thing on her badge that can show she can get in and out of her own residence. But what I recommend for LHDs, local departments, reach out to your emergency management. That entity within your county will have information on game days, operations, watch parties, any effects that they're doing. If you haven't planned for it, it's a little late in the day now, but there is always time to get some kind of response. There's never too late. We sometimes respond after event happens, not during it. We don't get much notice, so that's okay. You don't get points taken off for that. We will just still operate and function that way. So reach out to emergency management division or department if you have one in your county. If you don't, well, let me go back up. If you do, they may have a website where they have posted information on preparedness. I know most of them will have some kind of website that talks about preparing for the event, give you road closures, your law enforcement and your traffic control and your city services will have that on there also. So they'll be able to help you for that if there's any rollover into your area from that. For example, Sugar Land is actually a host city here in Fort Bend County. So we have a lot of operations going on there before any soccer ball even gets kicked. There already been operations there. So they've mitigated that. They have cooling stations. It's going to be very hot. There's already been some instances of the players that haven't acclimated very well, having issues with our Texas heat already. So for the public, public health, look at those websites, look at those partners. They can help you mitigate. They'll have information there on how to prevent overheating, have information on how to avoid traffic that you don't want to sit in. It's no fun. And then also have you options for where you can go in lieu of maybe those roads. They can divert you around to somewhere else. For clinics, I reach out to your public health if you can. If they have information, like here at Fort Bend County, we have, of course, our plan, and on our website, we have everything from extreme heat, extreme cold device. We have a go bag if you need those for if, God forbid, some reason you have to leave. But we also have information with the EOC. They put out what we call a sit rep for us. So we can have information we can then pass on to the public. Part of that information, like I said, road closures, any type of area that may be indicated for a lot of maybe traffic that may be an unexpected time of day, foot traffic, or an event that is a impromptu. They can put those out pretty quick. There will be some impromptu parties. I don't know if you guys know this, but these watch parties are going to pop up on their own in certain places, and it could be one even in your county. There's fans everywhere of different teams, so that's a real event that we're anticipating.
Thank you, Charles. All right, we're going to move on to our next question. I believe, Kenton, you were going to speak to this one. How far in advance does a preparation planning start for these large scale events?
Yes. So for World Cup in particular, the first planning conversation I remember having about this was late in 2023. So years in advance is when they start planning for large scale events, whether it's a like Super Bowl, that in advance, Final Four, or some things in advance. But there's other things that have shorter preparation time. Like if the Astros happen to go to the World Series, then yeah, that's a shorter preparation time. But for large scale events, sometimes 2-3 years in advance, you start thinking about what are you going to do from a security perspective, from a public health perspective, and you start getting those partnerships and pieces in place so you can be prepared if something happens.
Thank you, Kenton. All right. Our next question is for Dr. Mosco. This is regarding wastewater data.
Sure. So, wastewater data is an important public health tool in terms of managing or looking at a potential signal for an infectious disease outbreak. So, as when someone is infected, with COVID, measles, with other types of influenza, they're shedding virus, and that ends up in the wastewater. And so, this is a critical time during World Cup to be tracking and measuring wastewater data. It takes about 2 to 7 days maximum from data collection to actually getting a result, and understanding that there's an increase in actual pathogens that are found in the wastewater. So by creating an action plan and monitoring more closely that wastewater, we can actually pinpoint if there's an increase in some kind of an infection, which then allows us to plan, for example, scale up what's available in hospitals, make sure that there's centers that are already working with clinics, so that if folks are having symptoms, we can get it out. Communications as well. If we're seeing an uptick in a certain type of say virus, and these are the symptoms associated with that virus, we can now sort of get a public message out to make sure that people are aware of it. So it allows us to stay ahead of any potential outbreak before we all of a sudden are seeing 100 people at the hospital sick and we didn't know it was coming. So using wastewater data is a critical component for planning any kind of a large event that's going to be long term. If it was a one-off, it's slightly more difficult, but for a long-term event like the World Cup, where you're going to have people coming and going and you're going to have a lot of things happening, we can use it as a clear data point to gather that information and help us put potential plans in place to accommodate any kind of an outbreak that could potentially happen.
Thank you. Next question is for you, Charles. How to approach emergency preparedness for our older and disabled population?
Yeah, so this has been a mandate set by the state actually 2 years ago. We have a platform here in Texas called STEAR, or STEER. That's State of Texas Emergency Assistance Registry. This is free to the public, and if you have any either mobility needs like transportation, if you're bedbound, or if you have durable equipment, you're going to need assistance of any kind, you self-register into this platform. It goes to that local county. And here in Fort Bend, along with our Emergency Operations Center, our EOC, and our IT, our GIS, our mapping, we have plotted these locations for registrants that have maybe needs or assistance. We've also had this information passed locally to our first responders, our fire departments. They're aware of it. Mainly so we do welfare checks, and it's a lifetime map screen, a GIS screen we have that we can actually go and see what we've done so far, check an area that maybe need evacuation, may need support, may need transportation, may need to shelter in place. We're able to do that in lifetime in the Emergency Operations Center when stand up. We do this during blue skies, if you will, during normal times. We do an outreach meeting. We actually help register these individuals that qualify to be in this program to be registered so that we can plot them then, of course, and follow up with them if and when an event occurs, like I said, on the map and with our first responders. So we're using that to help us narrow them down. That way they don't call 911. We actually have the location, know them. We can actually have their information in there that we know what their needs would be. We know their contact number. We have a second contact number. We have a relative number. We have their address. We have their pets. We have the durable medical equipment they made. So we know all that. That's in our data we get from the state that they register with. And then we can plot it, like I said, on a map. And then, of course, reach out to them directly. We're not using efforts and resources frivolously in wrong areas that may have already been evacuated. You go right to them.
Thank you, Charles. The next question. This is about continuity planning. I think Kenton and Charles, or I'm sorry, Charles and Dr. Moskov, we're going to touch on this briefly.
I mean, sure, I can start, and then Charles, please jump in. Continuity planning is emergency management planning and putting these systems in place is not a one and done thing. You'll see an organization, you'll see a county, a hospital, a state, whatever it is, put together an emergency plan, and they're like, great, we've done it, isn't that wonderful? That's step one of an endless, number of steps that have to take place. So, one of the things that's really important to do as you do these plans is to constantly touch base. There's an expression which I do not like at all. Building the plane while you're flying it, which is you don't have the luxury of doing that when you're in an emergency. Decisions have to be made very, very quickly, but you don't want to wait until an emergency happens to test your plan and make sure that it works well. And so one of the key components in terms of the emergency management planning cycle is looking at how you can do testing scenarios, things like tabletop exercises, simulation exercises that are constantly allowing you to look at the plan, tweaking it. Let's pretend that there's some kind of an outbreak happening. In Galveston, we do an all-island response or emergency where you've got a hurricane, you've got a fire, you've got all these other things that are happening at the same time, and we actually have ambulances running in the city. We pay actors to come in. We do all these different things to really test, is our plan in place? Are the systems working? Or all the things that we've been training and practicing on, are they there? And then we do a very deep analysis of what works and what doesn't work, and then we can tweak our plans and we say, oh, this didn't work, we need to do more training over here, we need to adapt this over there. So looking at those testing scenarios, constantly making it a part, your emergency management planning a part of your everyday sort of workload, and thinking about, okay, how are we maintaining this, is critical. And your emergency plan should be reviewed and updated every 6 months at a minimum, would be my recommendation. I know we're running out of time, so Charles, please, whatever else you want to add.
Thank you, Dr. Michaels. Yes, she mentioned, it is a living document. It is something we always address, we always change, we always update as needed. Part of what we do here in Fort Bend County Public Health, we have a COOP plan, COOP, Continuity of Operations Plan, we call them. Each division has one. And my division, of course, oversight for plans, we house them and we make sure that we have them updated. It's something that you need to update. One of the biggest things is points of contact in that plan. People come and go, names change, positions change, even programs, functionality change. So if you're not looking at these, seeing what you do during blue skies, and that when you go in gray skies, remember the goal is always to get back to blue skies. You try and do that, get back to normal life as best you can. The COOP plan is what helps you do that. Have those functions that you would do during blue skies, start getting those back into place. So we update that plan every year. We go through it and vet it for its ability to do what it says it does for each division, and then also points of contact. That's something real important. We actually have to have those right names, right numbers, because otherwise you're just sending a message out in the ether. It's never going to come back, and you're going to have a lot of work to do following with that. But she was absolutely right. It's a living document. We always work on it here annually at the COOP plan.
Thank you both. I know that we are approaching the end of our session. If you will just allow us just a few more minutes, we have our final 2 questions. I do see there are questions in the chat. Please know that we will make sure to provide you all with the answers in our recap email once we complete this session. I'm going to move forward with one of the final two questions, and this is for you, Kenton.
So for me, like, the question like what skills or experience are most valuable for helping out in transition from education to public health. So for me in particular, just the teaching skill, because so like for training and exercise, as I mentioned, you do conduct trainings. I know some people mentioned about FEMA courses. So personally, I am I'm certified to teach FEMA courses. So like your incident command systems, which is basically how do you organize the response. I teach some of those classes as well as some of your EOC or Emergency Operations Center classes as well. So that teaching skill translates. Some people ask like, well, how's it going from kids to adults? Taught high school, taught adults. Hate to say it, kind of same, but but it's one of those things where like those skills translate. And then so another thing is like as a teacher, you have to be a good communicator. So your communication skills are critical in public health, especially emergency management, because it's all about relationships and partnerships. So being able to communicate as a teacher in education translates over to public health because then you can know how to communicate with your various partners and entities as you're working through it. Another thing is that I didn't realize is planning. So like as a teacher, you always have to have lesson plans. But those lesson plans, you're doing it daily. Those skills that you work on developing that plan for the week or month or whatever, those skills counter what you want to do. Some of those skills translate over to training and exercise. When you're developing exercise, it's like, okay, what's the plan for this? What is the scope of the exercise? What are we actually testing? What are our objectives? What are people trying to accomplish? So, a lot of times I didn't realize how many things in teaching translated to public health, but just had different names. So I feel like that's one of the biggest things in emergency management. I feel like a lot of things that you do in emergency management, you probably do it somewhat in your regular life. You just don't call it that. So there's a lot of acronyms and a lot of titles that are a little bit different. But when you start looking into emergency management and public health, some of those skills translate over if you're coming from a different field.
Thank you, Kenton. And to our last question, maybe if you, Kenton, or Jesselyn may want to answer this one, and it's in regards to sharing insights on breaking into the field with no emergency management background. Are there resources to explore, such as specific courses and trainings? I know it kind of follows up with what you just touched on, if you want to close that out.
Sure, I'll go ahead and close it out. So for me, I feel like one of the biggest ways of just breaking into it, as I mentioned before, internships and I would say mentorships. So I guess the fuller story of how I got into public health, like the emergency preparedness, it was really random. My wife, she was working as a nurse practitioner. Her first job, her doctor was an MPH. He was an MD MPH. And so I talked to him. And then he randomly just said, "Hey, why don't you try to see if Texas Department of State Services has an internship?" And then I reached out to them in 2018, but my timing was off. And so 2019, I was still like in my program, and I, started exploring and found out about preparedness. Had no clue what it was. And then just that internship opened me to a new field that wasn't covered in my master's because it wasn't that common at that time to talk about emergency preparedness in public health. So literally, like I was thinking I was probably going to be an epi or something like that. But when I saw emergency preparedness, I was like, oh, this fits me. This is more of what I want to do. And so like, through that internship and networking and mentorship, those are the ways to kind of break into it. I feel like it's a little bit easier now to find people that are in that background and just reaching out to them. Sometimes you can cold call people. That's what I did. And, just be proactive. Like that's one of the key things. Just if you really want to break into it, find somebody that can help you get into the field, learn from them, talk to people, and that networking, it can put you in front of the right people, and then you can break into the field. And for resources, as mentioned, I think Jasmine put in the Q&A, those FEMA courses, you can start taking FEMA courses right now, the independent studies. And if you take those, you can go to different websites to sign up for other FEMA courses or other emergency management courses, because FEMA is not the only game out there. There's a lot of different preparedness consortium courses and different agency organizations, too many to name right now. But that's a good start if you saw that in the chat.
Thank you, Kenton. Okay, and we're gonna go ahead and close out our webinar. Give me just a moment. So we have this QR code here on this flyer. Feel free to access this resource. Again, this is just providing a resource to you all for how to explore a career pathway in emergency preparedness. You see here to the left, there are different avenues that you can go with this, various roles if you are interested in a career in emergency preparedness. And again, we are approaching our fourth webinar. We've closed out the third one. Today we covered emergency preparedness. Previously, we've covered community health workers and epidemiologists in this Passport to Public Health series. So next, we're going to cover sanitarians. The date and time for that webinar will be provided in the coming months. Again, we meet quarterly, so sometime in the fall, look out for our next series or webinar, excuse me, and we're covering the destination of sanitarians. Please feel free also, if you're interested in joining the pipeline, the public health workforce pipeline, any of the groups that we offer through the pipeline, please highlight that QR code. Feel free to peruse through that and join one of our work groups. And we have our last slide, which is our survey for today's webinar covering emergency preparedness. Feel free to go ahead and scan your QR code there and let us know how we did. Let us know if there's anything that we excelled at or what we can improve on next time around. And we look forward to seeing you all in the coming months. I want to do a special thank you to each of our panelists, Kenton, Charles, Jesselyn, and Dr. Beth Ann. Thank you guys for your time. Thank you for sharing your insights. Thank you for giving us all a look into your world of public health, emergency preparedness, your journey throughout this part of it. And we look forward to seeing you all soon. You all take good care. Have a great rest of your day.